Thank you so much. So without further ado, I would love to introduce my colleagues, Dr. Jindani and Dr. Sinha. I'll share a little bit of information about their backgrounds. Dr. Shilpa Jindani graduated from SMS Medical School in Jaipur, India, and completed her residency in family medicine at Fletcher Allen Hospital in Burlington, Vermont. Dr. Jindani was a practicing family physician for more than 15 years, and currently it's our pleasure to have her serving as CalOptima Health's Medical Director for Population Health and Health Equity. Dr. Mohini Sinha graduated from Patna Medical College and Hospital in Patna, India, and completed her internship and residency in pediatrics at Kings County Hospital in Brooklyn, New York. For more than 19 years, Dr. Sinha was in pediatric clinical practice, and we're currently fortunate to have her serving as the Medical Director for Quality Improvement here at CalOptima Health, overseeing our quality and HEDIS initiatives for our Medi-Cal population. So without further ado, it's my pleasure to transition it over to Dr. Jindani to get us started with today's workshop.
Hello, everyone, and good afternoon. Thank you for joining this webinar today, and we will be going over the initial health appointment, what is new in 2023. I am Shilpa Jindani, and I will be presenting the general overall requirements for IHA. And my co-presenter and colleague, Dr. Sinha, will be focusing on the pediatric population requirement of IHA. Also, we have no financial interest or relationships to disclose today. First slide, please. So effective January 1, 2023, the DHCS All Plan Letter APL 22030 provided some guidance regarding initial health appointment, which was previously called initial health assessment. So the two changes that happened were, firstly, the initial health assessment is now the initial health appointment. Secondly, the Staying Healthy Assessment tool, the SHA tool, which we are very familiar with, is no longer required as part of the IHA requirement. The IHA visit does not need the Staying Healthy Assessment tool anymore. The standard screening requirements for each age group are still in effect. DHCS will measure primary care visits as proxy for IHA completion, leveraging on HEDIS and MCAS measures specific to infant and child adolescent well-being visits, as well as the adult preventative visits. Next slide, please. So IHA, or initial health assessment appointment, is a comprehensive assessment for newly enrolled Medi-Cal members and must be provided in a culturally and linguistically appropriate manner for the member to improve healthcare disparities. This appointment allows the member to establish care with their primary care physician and obtain all the necessary healthcare needs and preventative services which can lead to positive health outcomes. This needs to be performed by a primary care physician within 120 days of enrollment into CalOptima Health. And the primary care physician should document this in their medical records. So that is very important. Completed in the first 120 days, and the documentation in their in the member's medical record is important. Along with that, it may not be completed by specialists. So let's go over the definition of primary care physicians. Next slide, please. So per DHCS, the primary care physician includes internal medicine, pediatrics, OBGYN, family physicians, perinatal care providers during a member's pregnancy, nurse practitioners, physician assistants, and PCPs in training. Again, specialists should not be performing the initial health appointment. Next slide, please. So just to give you an idea about what are the components that are required for the initial health appointment, it should include a complete history, a head-to-toe physical exam, and assessment of health behaviors of the member. A comprehensive history includes physical, mental, family, social, complete history to get some kind of risk assessment for the patient. Next, it needs the assessment for preventative screenings and services according to the age and risk factors for the member. Identification of health risk is very important. It can be done through health screenings and standardized assessment tools in the office. Some of the tools that can be used are for depression, anxiety, and substance use disorder, like PHQ-9 for depression, and Audit C for alcohol screening. These are just examples, but the other standardized assessment tools can be used as well. Once the physician makes an assessment and identification of the health risk, they should document a diagnosis and a plan of disease treatment, which can include, if they have done a dental assessment, they can refer the patient to a dentist if required, or to specialist as required by the member's medical issues and needs. They also can help the member get coordinate care with other community resources like benefits or other community groups. Like if the patient requires health education, then they can be referred for health education. And this is a great way for care coordination and coming up for with a follow-up plan. Next slide, please. So for all members, the requirement is to get a primary care visit and an assessment of need for preventative screenings of services as recommended by USPSTF, the United States Preventative Services Task Force. Also, the IHA components can be completed over the course of multiple visits within the 120 days. And the PCP should make reasonable attempts to contact the member and schedule an initial health appointment in a timely fashion. All the documentation of patient outreach, such as member contacts, outreach attempts, and appointment scheduling, should be documented in the member's chart. So the requirement is to make at least 3 documented attempts to schedule a timely initial health appointment, which should include 1 phone call and 1 letter. And these documented attempts in the chart will be considered evidence of meeting this requirement. Next slide, please. So as we have been talking about the United States Preventative Services Task Force, which is the task force which makes evidence-based recommendations about clinical preventative services, we would like to go over a few of these. This is not an exhaustive list. We will be providing all the A and B recommendations at the end of our presentation as a resource. But I wanted to bring to your attention a few that have changed or some new recommendations that have been added. For the Preventative Task Force recently added anxiety screening and depression and suicide risk assessment, actually just in June of this year. And the depression screening should be done for all members, all adults, and the anxiety screening also under 64 years of age. And this includes pregnant women and postpartum visits as well. And they found that it was effective in identifying these conditions so adults can receive the care they need. Other screening that have changed, so the breast cancer screening, the age has been changed from starting the recommended age is 40 years instead of 50 years as it was last year. And this just changed in May of 2023. So breast cancer screening should be offered to all women over age 40, and it's usually done every other year, but depending on their risk factors, this needs to be discussed with the patient. Colorectal cancer screening, the age is now between 45 and 65. And also, of course, the gold standard is a colonoscopy, which is done every 10 years. But as we all know, it is not that easy to get patients to get appointments with GI, with gastroenterologists. So there are other methods that can fulfill this requirement, which includes Cologuard testing, which is the DNA stool test, and it can be done every 3 years. There's also a FIT test, which can be done once a year. So these are the few different screenings that we wanted to bring to your attention. The healthy diet and physical activity should be discussed. I think every visit, this should be brought up. and it is for cardiovascular disease prevention in adults who have cardiovascular risk factors. But even otherwise, it's a great way to educate your patients about healthy diet and physical activity. Next slide, please. So during the office visit, patients always get their vital signs completed, and that can help us complete the guidelines or recommendations for hypertension and obesity. Of course, when we talk to the patient and they have history of hypertension, that is something that we need to discuss in greater length. Osteoporosis, as you know, is to be for females 65 and over, to prevent fractures, and this is an important screening to be offered to all the women. Tobacco use, initial and annual assessment of tobacco use for adolescents and adults should be done, along with alcohol and drug use screening. And these can be done with validated tools, and usually alcohol and drug screening is recommended for members 11 years and older. Once the alcohol and drug use has been, when the member has been screened, it should be documented in the chart, along with if you have provided any counseling or if there is a follow-up plan for additional evaluation and treatment. So documentation in the chart is very important, and also that helps you and us track all the IHA requirements have been met. So again, providers must complete all preventative screenings for adults and children as recommended by USPSTF. Next slide, please. So we wanted to share with you our cancer screening rates for 2020 to 2022 in the last 3 years. And as you can see, our breast cancer screening rates in 2020 were 59.5%, 2021 was 57.6%, and 2022, it was 57.8%. So hovering around 50th percentile. In the cervical cancer screening as well, it was between 50 to 60th percentile. 2020, it was 57.6%. 2021, it was 62.3%. And 2022, it was 57.7%. So the reason we are showing this is, of course, we can all do better. And according to the National Cancer Institute, the rate of the current rate that they quote for cancer screening for breast and cervical cancer is around 75%. So we have a lot of room for improvement. Also, healthy people target for 2030 is 84.3% for cervical cancer and 77.1% for breast cancer. So again, we encourage you to urge your patients to get their screenings timely and have the access to screening. So here at CalOptima, we are striving to create a culture of cancer prevention and early detection. And we would like to share some of the resources that we have. And one is, if you go to our website and then go to health tips. So here are some resources, and you can, one of which is the member health rewards. So click on the member health rewards. And then, as you can see, we offer a $25 incentive for breast cancer screening and cervical cancer screening. And also, you can download the form from here, and either the patient or the staff can fill out this form to get this $5 gift card. Just a reminder, I know that here it says 50 to 74 for the reward for completing a mammogram. The guidelines of USPSTF just changed to 40, so we are hoping that this will also change in the next year. But right now, this reward is available for all members 50 to 74 years of age who undergo a breast cancer screening timely. For the cervical cancer screening, again, there is a $25 gift certificate that you get if the cervical cancer screening is done in members age 21 to 64, which is the current guidelines. And this is done every 3 years, and it can be done in the office of primary care physician or OB/GYN according to whatever is accessible to the patient. There's also an incentive for annual wellness visit, which is a yearly wellness visit. But if we are using the IHA as an annual wellness visit for that year, then this is a good incentive. It is available for for Medi-Cal members age 45 and older. And there is also a provider incentive if they complete the annual wellness visit timely. So please, remind the patients to do their screenings, and they can take advantage of these rewards that we offer for timely interventions. And before I move on to Dr. Sinha, I also wanted to give you a little bit of a background on another initiative that we have here at CalOptima. It's called the Comprehensive Cancer Screening and Support Program. And this is for breast, cervical, colon, and lung cancer. And in this program, we are collaborating with various partners to work towards a shared goal of decreasing late-stage cancer, and so that all Medi-Cal members have equitable access to high-quality care. So please encourage your patients and increase their patient awareness, and urge them to get the screening timely, since cancer prevention and early detection of cancer can reduce deaths due to the disease and save lives. I will turn it over to Dr. Sinha now.
Good afternoon. My name is Mohini Sinha, and I'm the Medical Director for Quality Improvement at CalOptima Health. And I will be going over the pediatric requirements for the initial health appointment. Next slide. So it's important to know that the IHA requirements for patients who are less than 21 differ from those for adults. For children less than 21, the screening recommendations and the periodicity schedule must follow the AAP Bright Futures schedule. So in terms of the timeline for scheduling the first visit for your new patients, it's important to know that the timeline would be different. It would not be 120 days as it is for adults. For children less than 2, as you know, that these patients need to be seen very frequently at a 2 to 3 month interval. So for those patients, you would follow those guidelines and not the 120 days. In general, we recommend that for children who are less than 2, that they be seen as soon as you identify them, and certainly no more than 60 days from the date of the enrollment. The goal is to establish a medical home as soon as possible for your new patients and to address any preventive care gaps. The requirements for the IHA, as I mentioned, are the same as what is recommended by the Bright Futures. So in terms of the components which would be needed to be completed would be a comprehensive health history, a developmental history, nutritional history, physical exam, any age recommended preventive screenings, and as well as anticipatory guidance and health education. So these are the same components as are needed for the well child. So if you do a well child visit for your new patients within the recommended timeline, you would get the credit for the IHA visit. Some of the preventive screenings which are recommended are listed here. They don't include all of them, but the ones which you want to highlight are the blood lead screening, and I will talk about that in just a few moments. The developmental screening using standardized tools such as the PEDS or the ASQ, which is recommended, as you know, at 9, 18, and 30 months. And the autism screening, as you know, is recommended at least at the 18 and 24 months using the MCHAT or a similar tool, or anytime the patient, the parents bring up concerns. And of course, looking for screening for adverse childhood experiences using the PEARLS. And in your older kids, in your teenage population and in your adolescent population, you would be screening for substance use disorder and depression. I want to emphasize it's very important to code for the screenings which you complete, because the screenings completed for your new patients is also a proxy for the initial health appointment completion. Next slide. Again, as I mentioned, a lead screening is a very important screening that must be completed for All patients who are on Medi-Cal at the recommended age group. This is not just an EPSDT requirement, it is the federal requirement, it is a state law. So that those screenings must be completed. As you know, children who are on Medicaid tend to have higher risk for environmental lead exposure due to living higher likelihood of living in older housing. And as you know, there's no safe lead level, that even a small amount of lead in a small child can affect the developing brain and can cause impact the cognitive and behavioral aspects of development. So it's very important to screen at both 12 months and 24 months. Even if the lead screening at the 12 months is below the cutoff range, which is 3.5 micrograms per deciliter, you still need to screen at 24 months. As you know, this age group is the highest risk because they are more mobile, and they still continue to display hand and mouth behavior where everything inside goes into the mouth. So you have to screen at 12 months and 24 months. And children who are older also need to be screened if they've not had a previous screening test done. And again, because these children continue to remain at risk for environmental exposure from playing in the dirt, which can be contaminated with lead, or in contact with other environmental risk factors. In terms of the samples, either a capillary or a venous blood samples are acceptable, but keep in mind that a capillary lead level is not as accurate as a venous blood level, because those can get contaminated from lead, which could be present on the skin of the finger. So if you do have an elevated capillary lead level, then please confirm that with the venous blood draw. I want to spend just a couple of minutes talking about some tips on how to improve lead screening in your practice. The best way, of course, is to have the point of care lead testing in your office, where you have a lead analyzer and you can just test it on the spot. If you don't have that, then the next best thing to do is to draw the blood in the office and send it to the lab. If you're going to be testing the child for anemia, then you can combine the blood draw for the anemia along with the lead test. And of course, if you're providing the lead requisitions for the parents to go to the lab, make sure you have a tracking process in your office to track the labs which were not completed and remind the parents to complete the lead testing. In terms of the anticipatory guidance, that's also a state law, and that this must be provided to patients at well visits starting from the age of 6 months to 72 months of age. And this has to be documented in the chart in terms of if that anticipatory guidance was provided. Again, the goal over here is for primary prevention. You want to identify any risk factors in the environment and counsel the family to remove those from the child's environment so the child does not get exposed to lead. Another important thing I want to point out is that if the parent declines the lead testing, it's very important to document that in the chart. The parents should, there's a lead refusal form, which is on the CalOptima website under providers and common forms, which you can download and use in your office. And that's just a standardized form you can use for parents to sign if they refuse the lead testing. And that needs to be included in the record, or any other form which you'd like to use. But the main thing to know is that if the parent declines, that needs to be documented in the chart. We are required by the state to audit charts for patients who are missing the lead level. So when we are looking through the charts, we look for evidence that the parent declined the test. So that would ensure that the provider is in compliance with the requirements. Next slide. Just wanted to share some of our lead testing data for our CalOptima Health children for the past 3 years. As you can see, on the far left is the testing rates for children at 12 months. And although the rates have gone up from year to year, we're still less than 60% for the age group for 12 months. When you go to the 24 months, then the rates drop like 10% lower. So the rates are 47% for a 2-year-old. And then if you look at children who got both lead testing at 12 and 24 months, it's only about 1/3 of our population. And if you look at children who needed to get a catch-up testing, remember these are children who there's no record of a previous lead test. For 2022, there's only about 1/5 of the patients got a catch-up lead testing. So again, extremely important to have EMR alerts or whatever other resources you can use to identify children who are missing this screening and to implement measures to make sure that the screening is completed. Next slide. Just want to give a shout out to Lead Screening CME, which is upcoming. It's on August 23rd from noon to 1:30 p.m. It's open to providers and office staff, and we highly encourage you to sign up for this CME. And I believe there's going to be more information provided towards the end of this presentation, and look out for faxes and email notifications about this upcoming CME. Next slide. As I mentioned, well child visit completed for your new patients would serve as a proxy for IHA completion. So, if the well child HEDIS, there's a number of HEDIS measures related to well child care and preventive screenings. One of the ones which we want to highlight is the W30 HEDIS measure, which really just measures access to care in the first 2.5 years of life, and ensures that children are getting the recommended number of well child visits as recommended by AAP Bright Futures. So W30 HEDIS measure is a HEDIS measure which looks at two subgroups. The first subgroup is the 0 to 15 months, and the requirement is that they must have had at least 6 visits before they turn 15 months. So the important thing I want to highlight is that the visits must be completed on or before the 15-month birthday. Even a day late after they turn 15 months would not count for HEDIS. So it's extremely important to get the visits in, the recommended number of visits before 15 months of age. For the age group 15 to 30 months, they must have had at least 2 or more well visits on or before their 30th month birthday. The visits can occur must occur with the PCP, not with the specialist, but does not have to be the assigned PCP. In other words, any PCP PCP in your office could complete the well visit. And for children who are behind on the well visits, you could do catch-up visits to catch them up on the required number of visits, but the visits must occur at least a 14 days interval in order to count for HEDIS. Next slide. So just wanted to share some data on our rates for the 0 to 15 months well child care. As you can see, the rates have been going up year to year, which is encouraging. However, in measurement year, the MY stands for measurement year, 2022, the rates were just barely hitting the 50th percentile, which is what we are held to by the state as the minimum performance level. So we just barely hit the 50th percentile. And so definitely we want to get to the 75th and to the 90th percentile eventually. One of the reasons for not meeting this measure is when we looked at the data, we found that about 30% of this patient population in this age group were missing just 1 or 2 visits. And of those patients who were missing just 1 or 2 visits, at least 80% of them had a visit which was a sick visit or a non-well child visit. And so there was this missed opportunity where these patients who were missing just 1 or 2 visits could have had the well child care when they came in for some other type of visit. So that's something just to keep in mind, that when children who are missing gaps for preventive care or for well child visits come in for other types of visits, to use that opportunity to identify what is the gap which is missing and try to complete that when they come in, because you don't know when the patient will come to your office next. So it's best to get it done but while they're right there in front of you in the office. Next slide. And this is the data for 15 to 30 months. Again, the requirement, as you recall, is 2 visits between for this age group. We do a little bit better. We did go down in 2021, possibly due to COVID reasons. However, we did bounce back up in 2022. We do meet the 50th percentile, and we did meet the 66th percentile, but we didn't meet the 75th percentile. So 70% of our patients did get were in compliance with this 15 to 30 month HEDIS measure. Next slide. I wanted to go over some of the tips to increase well-child visits, not just for your new patients, but for all your patients, all your pediatric patients. One of the things which I want to emphasize is that there are a number of reports which you should be receiving from your health network or from CalOptima Health. These are the IHA gap reports and the HEDIS gap reports. The IHA gap reports are have very useful information. They have the date of the enrollment and the date on when the patient is due for by which date the IHA visit must be completed. Again, I want to remind you that for young children less than 2, you should get them in as soon as you identify them on your list. So this way you have enough time to do catch-up visits and you're able to establish a medical home very early. So just make use of those reports. The best practice would be to assign somebody in your office to monitor those reports, identify those children who are missing preventive care, and outreach them for an office visit. Sick visits, again, is a huge opportunity. Yeah, we understand that sometimes it may not be possible to complete all of the components during a sick visit. If you have the time, please go ahead and complete all of them. If you don't have the time, complete some of them, and then bring the child back for the ones which are missing. For example, if you have to do a vision and hearing test for a 4-year-old, that can be deferred to another appointment. But you can certainly go ahead and get the history and the developmental history and the physical exam, and of course, the anticipatory guidance to meet some of the components. Convert your sports physicals and your daycare physicals into well visits. This is especially important for your adolescent population who may not be coming in for their regular physicals, but they will come in for the sports physicals. We used to see a huge uptick in requests for sports physicals starting in August, just before school was starting. And that's a great opportunity to convert those sports physicals into adolescent well-child visits. Weekend and after hours are also very important to offer to your patient population to increase access, especially for children who are school going, so they don't have to miss school, and for parents who are working. We had in our practice, we had a Saturday clinic devoted just to well-child care, and I can tell you it was very popular and very busy. So the parents really liked having the opportunity to be able to come in on the weekend for the well child, and then make sure the patient has the appointment for the next physical or the next visit in hand before they leave the office, and then remind them a day or two before their appointment about the upcoming appointment. The one thing which I want to emphasize over and over again is that to make sure to submit all the appropriate ICD and CPT codes for your preventive well visit visits, as well as any preventive screenings that you've done, like if you've done the ACEs or you've done the PEDS or the MCHAT or the nutritional counseling for your adolescents. Then make sure to submit the CPT codes. Again, the well child visit for a new patient within the appropriate timeline would count as an IHA visit, would give you credit for that. If you did preventive screenings for your new patients, again, during the recommended timeline, would serve as a proxy for completion of the IHA visit. So it's very important to submit the codes timely and use the specific appropriate codes. I think that's the end of my segment. Now I will turn this over to back to Dr. Jindani to complete to go over the rest of the slides.
Thank you, Dr. Sinha. So the reason we are doing this presentation is, of course, to bring awareness about initial health appointment and also to share some of our statistics. So in Q1 of 2023, these are the IHA performance by health networks, and it's for you to review. The current compliance is averaging about 38%. I know that we are coming out of a public health emergency, and we are hoping that these numbers will only improve. And we are looking for an IHA completion benchmark to be at least 50% this year. So we encourage you to bring your patients and for them to establish care with you and get their screenings and initial health appointment in a timely fashion. Next slide, please. Among the members who actually completed the IHA, here are some stats of the members who spoke English showed the highest rates of completion. So for English-speaking members, we saw about 56% rate of completion, Spanish 28%, and a 9% for Vietnamese patients. The rest of the threshold languages showed about 1% or less completion rate. These numbers are actually comparable to our overall membership and the languages spoken by our membership, which includes 51% of English-speaking members, 24% Spanish-speaking members, and 8% Vietnamese. So the reason we bring this to you is it's always important to make outreaches which are linguistically and culturally appropriate to encourage members to complete their IHA in a timely fashion. Next slide, please. So I'm sure this is a question that everyone has. How do you identify members in need of an IHA? So every month, the health networks will send a list of newly enrolled members who have selected you or have been assigned to you as their PCP and are due for an IHA. I'm sure you also get member enrollment notifications. So we would encourage that you talk to your office staff to utilize these notifications and reports and identify the members who require or who are behind or who need the IHA and schedule the appointments appropriately. Next slide, please. CalOptima also provides monthly reports to the health networks and to their directly contracted CCN providers. And these reports identifies completed IHAs and the pending IHAs. Other ways that we train the provider is during the onboarding. The providers get training on documentation of IHA and timelines of performing the IHA. There are other newsletters and manual that are sent as reminders to providers. A very good resource that we wanted to bring to your attention was our website, www.caloptima.org. And we would like to show you that we have added an initial health appointment reference guide for PCP. And this is the reference guide, and it actually has the CPT and ICD-10 codes. It has the components and what is an initial health appointment, what are the components. Go to the next page. And when the timelines, and then these are the codes that should be used and are appropriate for IHA completion. Please look through these. The preventative medicine codes are actually the best to be used because they are comprehensive preventative medicine codes. And these give you a full credit for completion of IHA. So please look through these codes and utilize them as you see fit. Also, there are codes, next slide, please, which like Dr. Sinha mentioned, for the screenings that you do in your office. And these codes can be secondary codes that can actually help completion of IHA. So please look through these codes, utilize these codes. And if you have any questions, please send it our way, and we can always update our reference guides according to what the need of the community is. Next slide, please. So other methods of our supporting the health networks is our quarterly forums that we have with the health networks. We discuss the reports and the gap reports with our health networks, and also during the joint operation meetings and sending out newsletters. We also do member outreach. So when the member enrolls, they receive a new member welcome packet, and that includes the description of these services, and it encourages them to call their PCPs to schedule their initial health appointment. For our CCN members, the community network members, we just started this year. We launched an IVR campaign, which is an interactive voice response campaign to outreach members who are due for their IHA. And then we also follow up with through text campaigns, other mailings and newsletters to remind them to complete their IHA in a timely fashion within 120 days of plan enrollment. Next slide, please. So telehealth services are very important and have been very important, especially since the pandemic in our healthcare delivery system. So you can actually complete a lot of IHA components virtually through a telehealth service. The comprehensive medical history, including social family history, their mental health assessment. You can do risk assessment and assessment for preventative screenings, and provide health education virtually through a telemedicine visit, and then bring the patient back into the office for a follow-up to do a physical exam, and then other screenings as required, like if the patient requires a PAP or needs an order for a mammogram, or if the patient requires immunizations, then that could be done when the patient has the follow-up appointment that could be scheduled after a telehealth appointment. For the telehealth visits, the coding remains the same. The office visits or the preventative office visits is how it is coded. The only thing is that you need to add a place of service code or a modifier to show that it was done virtually on a telemedicine platform. But it does give you credit for IHA completion. And as we mentioned earlier, all components of IHA need not be completed at one visit. So this might be a good way of at least getting your credit for IHA completion, and then bringing the patient back for the rest of their follow-up visits and requirements. Next slide, please. IHA has health education, which is a very important component of the initial health appointment, and PCPs must assess the conditions that the patient has and requires management and other education that can help them take care of their health needs. If health education classes are also available through our CalOptima Health website, and we also offer health education classes in person, and they're available at no charge, and can be a self-referral or a referral from your provider, or referral through the provider. And these referral forms can be found on our website. As you can see there, these are the links. There are also other very good educational material that can be found on our website, and which you can use for educating your patients, as well as there are some shared decision-making videos that can be used during an office visit as well. So these resources will be in our handouts, and please take advantage of all these resources. Next slide, please. So going over the best practices for completing an initial health appointment, contact the member and schedule appointments as soon as you identify or you get the report that you have been assigned a new member. It is always good to get the initial contact done within 90 days so that they have enough time to support the completion of all the assessments that are needed within 120 days. Providers are held accountable for providing all the preventative screenings, but as we mentioned before, all the elements of IHA are no longer required to be completed at the initial appointment, as long as the members receive these screenings in a timely manner. Another very good way to complete the IHA requirement is to utilize sick visits. If the patient comes in with the acute visit like URI or UTI, it's always, and they are behind on the IHA, it's a good way to at least complete some of the components of the IHA. It's a way to combine the effort and addressing their needs of their sick visit, as well as completing some of the components, and then have them follow up to complete the rest of the components of the IHA. Post telehealth visits, like we just mentioned, always good to bring the patients back and to complete the in-person requirements of the IHA components. When the family members are identified who also require, during a visit, if there is a family member who has come in and and find out that they require an initial health appointment as well, then it's good to make appointments for them and talk to them about other family members who might be requiring these establishing care appointments. So take that opportunity to identify any family members who would require an appointment and schedule these appointments in a timely fashion. Also, we wanted to bring to your attention the California Immunization Registry. I think most of the providers are probably registered on this. This is a good way to get immunization information for your patients, whether they are up to date on their immunizations or if they require any immunizations. So if you are not, please register for this. This is a statewide registry. And this is a great way to track immunizations and make sure that the patients get their age-appropriate immunizations on time. And then finally, of course, the health plans identify the IHA completion based on claims and encounter data. So please send in your submissions of codes, accurate coding, and send them timely and accurate. Submission is very important. And also multiple applicable codes, like we mentioned before, should be sent in apart from the office visit or the comprehensive preventive medicine code. Please add all the codes that you can. If you've done a depression screen, or if you have done an anxiety screen or a breast exam or a PAP, every screening method that you've used for various screenings has a code. So you can use as many codes, even for counseling the patients, giving health education. Please add all these codes so that you can get credit for your services. There are ICD-10 codes, and also then add as many CPT codes to get the credit which you are due for. So in essence, or to summarize, I wanted to just give an idea of how a workflow can be for a patient who comes into your clinic for an initial health appointment. I know that there are multiple components that need to be reviewed, and it can be a pretty long visit. So when the patient comes in, and even before the patient sees the provider, there are certain screening tools that you can use, which are validated tools for depression, for anxiety, which can be given by your MA or your nurse or your front desk to the patient. And as they're waiting, after they've gotten their vitals done and they're waiting for you, they can complete these screening measures. And so when the provider comes in, they already have these screenings and vitals, and that they can start their conversation with the patient. And this helps build up, the risk assessment of the patient. And then depending on the age and the family history and the risk factors, you can talk about the screenings according to the USPSTF guidelines. And if they have past medical history of certain chronic diseases, you can provide education. So just starting with the basic screenings, and then talking to the patient about what you have collected already, and then going over their chronic conditions or their medical needs, or if they need any referrals to specialists, that can be done. And then, of course, lab testing is very important. So sending the patient to get the labs as required according to their age. And immunizations, it is required. So a lot can be packed in the same visit, though you don't have to do everything in the same visit. And it is recommended that you bring them back to go over lab results, or if they require any other assessments, please bring them back. And multiple visits you can utilize multiple visits to finish all the assessments that are required according to the USPSTF guidelines. So this is our presentation, and we are hoping that you will utilize all these recommendations that we have shared and help us achieve our goal of increasing our IHA rates and increasing our screening rates so that the patients get to their health goals and their needs are met, and they have a much better they receive care that is needed and also a great quality of life. So thank you. And I will turn it over to Stephanie first to go over the resources that we have mentioned, and then we can take questions.
Great. Thank you, Dr. Jindani. So now I'll go over some of the resources that we have. I know there was a question or two in the chat that we might answer on this slide in particular here for you all. So first, we have our health and wellness webpage. We'll open that up for you right now. And we have the pathway of how to get there as well. And this webpage here, let me wait for us to catch up. So you'll go from the main CalOptima page. And this health and wellness webpage, this is provides a lot of health education materials for our members. So this is actually going to be accessed through the members tab at the very top. So we'll click on members, and on the left-hand side under health and wellness, you can just click on the self-care guides, and that will take you to our main page. And here you can see we have a variety of topics on different health-related topics and conditions here. Any of those you can click on to view more for more information about a specific topic. So for example, let's click on diabetes management. Actually, let's click on cancer because we talked about our cancer screening health rewards. So if you click on view more, you can see this is an actual list of videos. So all of those titles in blue, those are videos that can be watched. They're short, about 2 or 3 minutes, and they provide a lot of good information to our members. Once we scroll past that on the page, you'll also see a little bit of information about the specific topic. And towards the bottom of the page will be any related information such as PDFs or other documents, health education materials that can be used for members. And I think that might have answered the first question about our, let's see, educational pamphlets available to our members. We also do have a health education library, which we'll go over as well. So I'm gonna go back now. We're gonna bounce back and forth between the presentation and each resource on the presentation. So I believe next we had the referral form. So we'll go back to our home page. And we have the referral form there, so you have an idea of what that looks like. And I believe that's in the process of being updated. Excuse me. So from our, let's go back to our home page, and I'll tell you how to get there. So we'll go to find this under the providers tab. So we'll click under providers, and then we'll look for the header of resources, and under resources, we see common forms. So we'll click into those common forms, and it's in order alphabetically. So we'll look under the H's. And there we go, the health and wellness referral form. So as Dr. Jindani mentioned earlier in the presentation, if you do have members in need of additional health education services, this is where you'd come to access the form. You fill that form out, and at the very bottom of the form, there are instructions as to how to get that back to us. One important thing to note, if you do have additional information, if you want to attach labs or notes, you are welcome to do that on these referrals as well. Okay. So number 3 on our list, we have our wellness programs and services website or web page. And that's accessed under the members tab. So that's basically where we were before, the same pathway to reach the self-care guides you'll see in these blue tabs up here. That was just on this page. So you can click into the blue tabs to see the wellness programs, and yes, that one. And so you'll see a list of all of the services we provide information about, more information about what members can get access to. And if we scroll a little bit further down, I believe we'll have, we won't be clicking into these now, but you can access the PDF versions of our flyer there as well. All right, so let's go back to the presentation. And next on our list is the blood lead refusal form. So this is something that Dr. Sinha mentioned in her presentation. So we want to make sure that you have access to this form and know how to find it. This is also found under that common forms pathway for providers. And it's located right at the beginning in the A's under the anticipatory guidance, and that is available in multiple languages for your patients and members as well. I think we went a little too far. I think it's under the A's. There we go. So you'll see that there, and you'll see that we have multiple languages available as well in that document. Okay. Next on our list from the presentation resources slide deck is the IHA reference guide for providers. I believe somebody asked this question in the chat as well. So I will show you how to access that link here. So we can see that on the screen. That's what that PDF looks like. So from our home page here, you'll go under providers, back under that resources umbrella there. Health education is where we'll go this time. And once you click into that and scroll down, you'll see there, that's where you'll find the IHA reference guide for providers. So the first page of that document is basically a summary of what Dr. Jindani presented at the beginning, some information about those general guidelines, also some information from what Dr. Sinha presented on. And then if you go to the second page, you'll have some information as far as the CPT codes that can be used. And I do want to just emphasize the top half of that document are those preventative office visit codes that we're looking for as a main source of that IHA completion. All these others below, those are definitely great to use as support along with those office codes. And then lastly, we'll go back to the PowerPoint, and this isn't necessarily something that's on our CalOptima website, but we did mention it in the presentation, and it's important for our providers to have this link. So we did post the USPSTF guidelines link there for you as well. I'm going to pause. I know that was a lot of information, and I did see an additional question come into the chat about something we just reviewed. So if you don't mind, I'll just take a second to address it now. Balan, if you don't mind going back to the page where we have our videos, please. So that would be under the self-care guides. And somebody asked, are these videos available in Spanish? They are available in Spanish, and I want to show you how you can change the language. So if you don't mind clicking back into the view more for us, I want to do the view more so it's larger on your screen and easier to see. And if you can just click into the video and start to play it for us, and it'll show us the settings. You can, okay. So you see the little circle on the lower right, the settings. If you can click into that for us, you see the language there. You can change the language to Spanish, and then you can view the videos in Spanish. Once you change it, all the videos after that should continue to be in Spanish. I don't think it's saved. We'll try it one more time. There we go. So now you can see that that's in Spanish. Okay. You're welcome, Jane. All right. So I'll take a pause there. That's all we have as far as our resources go. Hopefully that was very helpful for you all. Our next slide I'll jump into now is more information about our next CE CME. As Dr. Sinha mentioned earlier in her presentation, we do have the prevention of childhood lead poisoning coming up, and that is for 1.5 CE and CME credits. Our presenter will be Dr. Jean Wu, and she is with the Childhood Lead Poisoning Prevention Branch of the California Department of Public Health. So we look forward to hearing more information about that from her. Please mark your calendars. That will be held on Wednesday, August 23rd, same time as today from 12 to 1:30. And it's absolutely recommended for providers, case managers, any office staff that need support with the blood lead education efforts. So we definitely welcome all. And just stay posted, like we mentioned earlier, to those fax notifications, email reminders, and we'll have that link coming out very soon to register. Okay. So I think that's all we have. Our next section is for questions, comments, and answers. I believe I answered most of the questions already in the presentation. But let me just review one more time to make sure we didn't miss any. One moment. Okay, I see one that I did miss. It was, if the physicals were done in the early part of the year, are we still able to submit the forms for annual wellness visit? So actually, you don't have to submit a form, and the member health rewards date range for the annual wellness visit, that's also including the social determinants of health assessment. That's going to be for visits done between April 1 and December 31 of this year. So yeah, there's nothing that has to be done. I believe we're using the claims data for that. Let's make sure we didn't miss any other questions. Let me take another pause and double check. If anybody does have any other questions, please feel free to write them in the chat or in the question and answer section of the below section of your Zoom application. Okay, I'll take a pause just to check in with our team here to make sure that I answered all the questions. Please feel free to chime in if I missed anything. Otherwise, if I don't hear anybody interrupt me, I'll move us forward. Okay, I'm actually seeing a comment in the chat, so I want to address that and go over it. Anna is reminding us that each of the videos that you saw under the self-care guides page that we went over, they do have an option to print those out as PDFs. So let's go back to show what that looks like. If you don't mind, Baoan, opening that up for us one more time, the video. Okay, and would you mind making that large screen on the video? Yes, thank you so much. All right, so you can see this is in Spanish, so it might be easier for our audience to switch back to English. Thank you. Now, it might be small for you all, so if you do have your computers open, I definitely encourage you to pull up our website, come here now, try to do it on your own. That way you can give this as a resource to your patients. So from the video at the very top on the left side, you'll be able to see there's a little button that says print brochure. If you click on that, it will create a brochure version of the video that you just watched. So basically what the video is saying is written out here on a brochure. The nice thing about this brochure is you see that QR code at the upper right-hand corner of the brochure there. Let's say you like what this video has on it. It's precise about what you're looking for. You print this out and hand it to a patient. That member now can go on to that page, look at that page later. They can pull out their phone, scan that QR code, and that will take them to the video so they can easily access it later. And I don't know if you can make that bigger, Baoan, for us. I welcome you to try to scan it now. It might be kind of difficult. I know PDF, when you make it bigger, it's not scaling for us. Thank you for pointing that out to us, Anna. I think that's a great opportunity to get people on here to get some more information if they need it. And while we have this area up, I don't know if I necessarily went over it, but I'll go back to our health and wellness page and just make sure you know how to find our member health rewards section as well. That's under the member section. And then you can see the member health rewards there. Yeah, if you click into that, you can see all of the different member health rewards that are available to our members and the eligibility criteria that goes along with it. If there is a form that's needed, you can download it. Well, all of them actually do have a form. However, not all of those forms actually require you to take action and submit something to us. Some of them do, some of them do not, like the annual wellness visit we talked about earlier. And I see that Katie just put a link in the chat here for us that there's additional information for providers about the Medi-Cal annual wellness visit program there. Okay. I'm glad we're going over this. Any other questions? Feel free to ask. All right. Anybody on our team, if I missed anything or there's anything additional that can be helpful, please feel free to jump in so we can review that or let me know. I'm happy to go over that. Okay. I'm seeing none, but I'll give it one more second just in case we're still thinking about things. I'm gonna go ahead and say it's safe to say we'll move forward then into our closing remarks.
Steph, can we just also remind everyone that in addition to this presentation, there is always communication that comes forth as reminders for the IHA. So of course, coming to us through the website or even sending members to us as referrals, that's great. But also look, please, through the monthly communication that goes out to providers. We often have updates and reminders about the IHA or anything that may come up as new, in addition to presenting any other opportunities that may come up.
Thank you, Anna. Thank you. Yes, we do make efforts to provide as much communication and information to our providers and health networks to help support you in your efforts to get members in and get those IHAs completed in a timely manner. We do appreciate your hard work and we want to make it easier on all of you. So we do have those communications going out and those reminders as well. And if you ever do have questions, you're always welcome to reach out to us. And thank you for reminding us of that, Anna. Okay, anything else before we move forward into those closing remarks? Okay. So at this time then, I'd like to thank Dr. Jindani, Dr. Sinha for your time in presenting today, and also all of you as participants for being here and attending this event. I would like to remind you all to please complete your evaluations. Let me see when those will go out. So please allow time after the training to complete the evaluation. The evaluation, it's going to pop up on your screen after you close out of Zoom. So we're planning to end a little bit earlier than anticipated. So it gives you that time to be able to complete your evaluation for us. We really appreciate any feedback that you have. It helps us to continue to improve on our CE and CME trainings for the future. If you do not see that survey pop up once the Zoom meeting closes out, please know that we will have a follow-up email being sent out tomorrow, and then that will have the option for you to click on the online survey and be able to complete your evaluation then. One more quick reminder, we want to remind you to mark your calendars for August 23rd from 12 to 1:30 for the prevention of childhood lead poisoning. All right, and with that said, we are done for the day. Thank you so much for your attendance. Thank you, everybody, and have a great rest of your day.